Introducing our panel here, all the way at the end we have Dr. Thomas Groff. Do you want to tell us a little bit about yourself and where you are?
Well, I'm a psychologist and I work at Driscoll. I'm one of the two psychologists at Driscoll, and I work in the developmental clinic. Basically, I see kids between 2 and 12, most of them. Developmental problems, autism, language delays, so that's one population. The other one is more medical problems, and kids get hospitalized for something, or kidney transplants, or diabetes. I see those too. So.
Excellent, thank you. And then we have Miss Julie Thigpen.
And I am I'm in private practice. I've been doing private practice for about 12, 15 years. I can't remember exactly. And I'm a LPC supervisor, registered play therapist supervisor, and I also see kids about 2 to 12 is kind of where I work. Kids that referrals from CPS and schools and different places. So I work the gamut of everything from 2 to 12 that would be needed for children. Mental health life.
Excellent. Thank you. And Miss Lene Canales.
Hi, I'm a pediatrician at ABC Pediatrics. I've been in private practice for 17 years, and I see children from birth to when they decide they're too old to come to our office. Usually about 18, 19, 20, somewhere in that range.
Yeah. 20.
Yeah, some do. I kind of cut them off at graduating from high school, but some of my partners.
I'm trying to imagine a 20-year-old like sitting on the choo-choo train.
Yeah, they no, some don't want to leave us.
Excellent. Thank you. And then Miss Ashley Martinez.
My name is Ashley Martinez. I work with MHID, so we used to be called MHMR. Now we're MHID. Been there for 3 years, mental health case manager. I work with children from the ages of 3 to 17. So we're kind of like that middle between your practices and the mental health authority.
Okay, thank you. So in everyone's packet we have a case study of a 7-year-old boy who is being raised by his mom. He hasn't had much contact with his father, very close to his grandmother because mom's picked up a second job and he's spending more and more time with his grandmother, right? Because of these transitions, he hasn't been able to play sports. He talks a lot about being disappointed about that, missing social interactions with other people that aren't his grandmother, aren't his siblings. He is closer to his younger brother, but that's become a little strained lately, particularly as younger brother spends more and more time with his bio dad. Mom is kind of reporting that he's been having a lot of anger outbursts towards the younger brother. He becomes tearful very easily, and having a really difficult time sleeping no more than 6 hours a night. So trying to wrap your mind around 6 hours of sleep for a 7-year-old is just wild, right? So the teachers have reported that basically he's usually a pretty average student, but recently those grades have begun to slip. He's missing assignments, not doing homework, refusing to do anything in class. And whereas he had kind of typically had difficulty paying attention, now seems incredibly distracted, irritable, short-tempered, has cry downs and things like this at school, especially around reading-related assignments. The school counselor, after trying some other interventions, basically met with the mom and referred them to youth services for a screening, right, which is where a lot of issues in our local school district, that's sort of their jumping point, is a school counselor administrator refers them to youth services from a screening. So let's start there. This family, mom comes in with this boy Brandon, and they walk in and they're like, "Hi, we're here for a screening." Can you tell us a little bit about what that process is?
So the screening is very simple, though it does take a lot of digging into to make sure you want to get all the key points. So we're gonna first start with who referred you. Generally we kind of want to know the background of what's going on. So what are the key behaviors, what's being observed in the school, home, and community. So if you're seeing a lot of issues at home, we usually start off there asking about, how's your anger outburst, or generally we might ask about homicidal, suicidal, things like that. We also want to focus also on risk factors, if there are any. And after we move from there, generally just gathering information. So, behavior, if you're saying any of that. Family dynamics, any type of trauma in his life that's related to a lot of these issues that we see. And once we complete that screening assessment, we kind of speak with the family more and talk about, okay, well, what are you really looking for? A lot of the times our screening process, people do just try to come in for medications. But once we talk with them and kind of explain more what we have in our services, they're more okay, you know, yeah, this seems like more behavioral issues, social issues that needs to be addressed. And so we'll move from there after the screening process.
Okay. So given what y'all got going on with your screening process, are anything here, you know, red flags, orange flags, something like that?
Lots of flags. So
Yeah.
generally, first off, let me see. Well, he's poor sleep hygiene. That's number one. Sleep hygiene's not that good. A lot of anger outbursts towards younger brother, of which there was a positive interaction. Now there's a negative interaction. School is another big one. So in his community, in his school, he's not doing so well at all. So we'll note on that as well. Irritable and short-tempered, easy to lash out or cry. Sometimes we want to know what type of lashing out are we doing? Are we doing more verbal or physical? There's a lot of difference on the extremity of what that type is, so we'll dig into more of that as well. His grades as well, what's causing meltdowns, a lot of triggers. We're really at this point trying to identify triggers that we can just quickly note in our screening.
Gotcha. And so for a case like this, would you say that the prospects for entering into a particular package of services was probable or not probable?
It's very probable. And so based off of our assessment that we do, so we have the screening, and then there's the intake, which follows after screening maybe a few weeks thereafter. Just based off generally, I would say he comes in at a level of care 2 package, LOC 2, which generally there's a set amount of services per each package. Depending on how intense the child is, wanting to come in at a 3 or 4, generally we have kids coming in at a 2. So just to kind of educate what a 2 is, LOC 2, you'll be getting case management. So that means I will be going, making sure all his paperwork's up to date, making sure he's taking his medicines properly when it's administered further down the line. And then I'll also be providing skills training. So in that sense, where we talk about, and this is thereafter the recovery plan, maybe we might be working on your anger, maybe we might be working on how to express our feelings. So also LOC 2, you'll be giving a psychiatrist. And then depending on a counselor, if you go up to a 3, but generally we're at a 2 at that point. So yeah, he'll come in at a 2.
Yeah, so within this package of services, there may be medical management of symptoms from a psychiatrist, like down the road or something like this. And there might be skills training.
Yes.
And skills training are things like anger management, social skills, things like this.
So generally.
Impulse control skills.
Right, so from a 2, 3, and 4, you will always have skills training regardless. The only time you won't have skills training at a 2 is if he has a mood disorder of some type, when that's diagnosed by the doctor, and we can determine if you want counseling or skills. But generally, based off of this, we would probably start working on aggression. Trying to work on that impulse and anger control, because that seems to be more of the primary issue that the case manager can deal with. And then we would go on maybe to outside referrals if needed for counseling added.
Which is probably where it usually comes into play, right?
Can I just ask something? So how long does it, how do they get into your office? You know, do they call? Is there?
We don't have a wait list. So generally, let's say we have someone come in and they're like, I need help. I'm like, okay, let's start with the screening. After the screening's done, depending on the intensity of the child, so if they come out of the hospital, we're gonna get them in within a week. If they come from just his background, it might be intake maybe 2 weeks out, just to start him to begin, because after the intake, then they would meet, the intake is with the counselor, and then they would come to me right after. So I would say within a month, this child would be in services. But if it's like hospitalization from Bayview, probably 2 weeks.
And you mentioned that level 3 is where counseling is
It's
usually
generally,
implemented.
right.
And so that's after you've assessed some other things.
Yeah.
Because I was surprised, and he thought when you said that you don't have a weight,
Right.
because we both have weights.
Yeah.
That happens. And so often when you're talking about, you know, even a month, people want to be seen next day or tomorrow. That's what I often find. And when I'm saying things like it might be 2 or 3 weeks before I can even look at the schedule to see what's happening, I don't see anything happening this month. They're like,
Yeah, we have it up to, we can see probably up to 2 or 3 months out
Wow.
generally.
Okay.
So it also depends on the like severity of the child, but if he were to come in right now, let's say I met him on Friday, I did the screening on Friday, I can say, okay, you're gonna come back first week of April, last week of March,
Okay.
we're gonna do your intake, the intake's 2 to 3 hours, be prepared, eat before you come. And then after that, we're gonna just move forward, so I would have 10 days after that intake to make contact with that child, I generally do so within 3. And then we start the recovery plan, and I can start social skills training right
And
after.
you're saying when you do intake, you're not actually doing psychological assessment at that point, that's just typical intake with assessing needs and
It would,
that type
it
of
would be a
stuff?
psychological assessment by the LPC.
Okay,
So
that
let's-
isn't done in the,
Right,
Okay,
so
cool.
you might have an LPCI that would do the general biopsychosocial, which is gathering information and data. An LPC would come in and they would review it and then give the primary diagnosis, which might be changed when they meet the psychiatrist if they go to psychiatrist.
So these are all like ages from 2 to 17?
From 3 to 17.
3 to 17, so kids who have like lots of learning problems to no learning problems?
Yeah.
Okay.
Interesting. So, again, it sounds like in about a month, things can really get rolling for
Yeah.
Brandon and his family, right? I sort of imagine if Brandon was like my child, I'd be like, in that month's time, I would probably go to my PCP, right? And so, Dr. Canales, can you talk to us about, if this hypothetical, family came into your office and they had mentioned, we've been here, we're about a month out from any sort of medication management type of appointment, with the skill training, they just kind of come to you.
Well, it's interesting because as you're all talking, I'm kind of giggling because my patients get in the same day. Like we except if it's a checkup. So when reading this scenario, first of all, I would have not gotten 95% of this information. Can't in 17 years in practice, I'm not sure I've ever had a scenario where they went to you first and then came to me. My patients, my experience has been, I'm the first line of defense, and it can come up in a lot of different scenarios, and I think for me, I'm the gatekeeper. I've got to figure out, if I send every person who had 1 or 2 of these, cause I'll probably get the falling asleep comment, like they're having difficulty sleeping, and I might get that in a scenario of a checkup where we've covered 20 other things, and then as I'm walking out the door, oh, by the way, he's not sleeping well. And so, for me, I've got to figure out, what does that mean, okay? And so the 3 things that when I read through the scenario that I probably would get would be the difficulty sleeping. He's fighting with his brother. I probably just get it like that. He's fighting with his brother. And we're having problems in school. I probably would say the majority of the patients that I get, the problems in school are the thing that they present with. And they might come in with that as an ill visit, we're having problems at school, or the counselor at school, or the teachers at school said I need to come talk to you. That might be what I get, or it might be in the scenario of a full checkup, and as one of 30 things that we talk about. So trying to identify who needs that next level of evaluation is one of my biggest challenges, and it's a time constraint, because there's no possible way I can get this kind of information in one visit.
Yeah.
And that would be different for us, whereas
Right.
a child comes in, depending on how much they want to talk to me, I could be there for a good hour during the screening. That's not normally generally
you don't have that.
what they want, but if a parent starts crying and they're telling me their story, I can't just say, okay, bye, see you in a month. I have to kind of de-escalate the problem, and I
You need to
want,
push the pace on this.
I'm like, sir, what's going on? But generally, I probably get a good chunk of this in a screening. And yeah, you're right, they would come from my PCP, sometimes they'll tell me, oh, I'm receiving medicines from my PCP, so they'll be like, well, I need this extra help, and so it's kind of.
Well, so Dr. Canales, can you share with us a little bit, you said like those 3 things, that's the type of information you get to parents, and so I'm wondering if you can talk to us a little bit about 2 things. Number 1 is like your process experience, like as you're hearing this information, like what's your process for how you're, situating the information, and then the second part is, what are your options?
Right.
What do you do?
So, this is where knowing your families also helps, because sometimes you know the family and you know their personalities, and some people share everything, and it's just they want a little reassurance and a little encouragement, and other people are only gonna bring something up if it's causing significant interference in daily living. And that's the thing, is like you have to assess well, they're having difficulty sleeping, does that mean, you know, you have to lay down with them for 30 minutes and read a book and that's annoying to you? Like, you know, I mean, what's the degree of this, what are we talking about? And that's very hard because people, I think, have different expectations of how their children should behave and what is normal and what's not. First-time parents different than someone who has 4 children and what their expectations are. So trying to elicit how is this affecting your child and your family unit, and is that significant? Because if it's significantly affecting them, even if it's not severe pathology, it's significantly affecting them and they need and want help. That's why they're bringing it up.
Yeah.
As far as like the difficulty in school, that one is a little bit easier for me because you know, that's such a common complaint, and trying to identify, and everyone thinks that if they're having difficulty in school, they have ADHD. And the reality is, I personally think that's overdiagnosed, and I think that a lot of, there are providers who, if you say that they have difficulty focusing, okay, you have ADHD, and they don't do a more in-depth evaluation. The reason I find this a little simpler for me is because I can start with some basic screening profiles. Like, I use the Vanderbilt, and that's a great, simple, fast tool to kind of give me a direction of where to go from there. So I have parents call a lot and say, teacher said they're having difficulty focusing, and I start with the Vanderbilt just as my screen. And from there, I can kind of decide, you know, where we're gonna go. I could not possibly refer all my patients that have school problems. I mean, we would overload the system.
Yeah.
So, right, so in general, most general pediatricians here in Corpus are gonna be doing a lot of this diagnosis and treatment and management. It's the more complicated, or, so on the Vanderbilt, if I get screening positive for some anxiety or depression, I've gotta tease that out, and I'm not qualified to tease that out. I don't have, you know, we're not set up to do that, and those patients I will refer on, say, okay, I need to know how much of this is anxiety versus true inattention, because as you all know, anxiety looks like inattention. And sometimes you have comorbid disease, and when you have
the sleep deprivation on top of that.
Right.
I think that's one of the ones years ago when I started in Head Start, it blew my mind how many parents thought that 7 to 8 hours was appropriate for 3 and 4-year-olds.
Yeah.
Because it was appropriate for them. And I literally could not even fathom that. And when you look at the symptoms of sleep deprivation in children, it's all the symptoms that show up in the ADHD categories. And so that was huge in my red flags when I'm paying attention to parents, when the behaviors are coming in sleep deprivation, like you said, teasing out what that means, because going to bed an hour worth of a process is very different from the kid has a hard time falling asleep or they're waking up in the middle of the night. I worked with a child that for a year and a half, and I knew she had sleep issues. I knew she wasn't sleeping, but it was in a random conversation with a parent where she all of a sudden says, well, we never get more than 4 hours. And I was like, never? No, not since she was an infant. Wait, hold on, she's 4 and you've never slept more than 4 hours? How many typical does she sleep at a time? Oh, maybe an hour and a half to 2. Oh, we need to call the pediatrician today because that's not okay. No wonder everyone in the household is having a hard time functioning, including mom. Within 3 weeks, they were on some medications to help sleep, and mom came back in, and I could see in her the difference.
Everybody in the
because
household.
she was sleeping more. And so those little things sometimes, like you say, that teasing out, you've got to start at the top and pull all the pieces, and you know, it's kind of like which one is the real issue, but you got to start somewhere.
Yeah.
And I think that's part of where I find the challenge is by the time they've made it into my office and they've come to the two of you and the school counselor and listened to all their friends and family tell them what they think is wrong, it's so big at that point.
Well, my experience has been that oftentimes they just want the quick solution. They want the prescription, they want the medication. I mean, that's kind of culturally, I think, in our society, that's a little bit where we've gone, unfortunately. And, you know, I've had patients that, you know, after doing their just the, you know, simple evaluation with the Vanderbilt and get the results back, I really feel like we need more evaluation. I don't feel comfortable that we have it right just based on these forms. They're just simply screens. But they don't want to go do the extra work sometimes, and they don't want to have that further evaluation, and they're just begging me, please, can we just try it? And like, you know, it's.
And that's
In
kind of
some
where.
ways, they may not have that coverage
Right.
for that referral, you know.
Exactly. That's
We may
it.
private
And it's,
referral
there's a
someone.
delay.
Yeah.
At
And
the-
the
they don't
delay-
wanna wait,
Yeah.
they don't wanna wait,
By the
and
time you
it's
see in
hard.
my office and they've had 2 months of another wait, it's just, and I think that that's part of where I also find is telling parents, there's a lot I even see here that is beyond just a behavioral issue.
Mhm.
He's had some grief and loss issues, he's having some anxiety show up, he's had the sleep and some of these other things, that part of what I tell parents, I'm gonna work on the emotional content and de-escalating and regulating, but the behavioral stuff is you and I. It's not the kid. I can't change behavior in 45 minutes a week. I don't have magic, you know, I wish. And so that's a hard thing, and a lot of parents, well, that's not what I was really coming for. And that becomes part of my challenge is I can't address all the behavioral issues in 45 minutes a week with a 4-year-old. They don't know how to take that home with them and make that work at home. The adults do.
Sure.
And so getting an adult engaged in that process is one of the challenges I face.
Well, and in these packages, services skills training extends also
Yep,
to the
to
parents,
families.
parent skills
Right,
training too.
so we have a family partner that works with the parent, we can do nurturing parenting with the family. Just with me, it's been hard, would be like for me as a case manager to work with that parent, but we have family partners that will come and be like, okay, let me work with the parent. And we do see better and quicker progress when the parent is
Oh, yeah.
also working on a lot of their needs, and then the child's like, wow, I'm happy, I'm like, well, I know, because we have other things going on that's just not with you, it's with the family that we're working on.
And because the things that you and I see in this type of an intake with the mom, I mean, we can look at mom, she's stressed, you know?
Yeah.
And so when you look at just the mom being the stress factor in the home, and then you add additional children in that, and there's a lot of changes this little guy has gone through. It's not just a behavioral issue in school.
Yeah.
And I think that that's where I think the multi-teams that you guys are able to employ at an agency become really helpful.
Yeah.
Is because you can kind of split that process and work with parents and children at the same time.
Absolutely. Dr. Groff, there's been some dialogue about teasing this out further, or, you know, learning a little bit more about exactly what the experience is with Brandon here. What's your thoughts? What's, you know, let's say there is no wait list.
Right?
Brandon's able to get in on Tuesday. You know, he comes into the clinic and is able to see you. What's your process? What are some of the things that you experience with the family, some of the maybe testing or evaluation, and then some of the outputs that you provide in terms of recommendations about all these things?
Well, there's, I mean, like there's pressure on the parents to do something about a problem. That's how they come into any of our offices. So, you know, who's putting pressure on them, and, you know, is it, and are there, like lots of people can look at the importance of certain things like sleeping and eating and how that impacts their ability to learn or pay attention, and you know, so there's some simple advice to them, and that can be just like important to regulate, and then lots of things can get better. So this kid probably wouldn't come to me if that's all it was, you know. So, but then once people start talking, they might tell you more. You know, it's more things impact kids, like how well they can speak, how well they can get their thoughts across, and so maybe there's some speech impairment in there too. Maybe they have stuttering. Maybe they have very short sentences, and or they're socially anxious, so they won't talk when they're put on the spot. So, you know, parents might not bring that up, and it comes up as they present the case. So if there's some kind of those like speech problems or communication issues, those are then assessed by me. So that's more cognitive functioning. So lots of kids have verbal delays, verbal cognitive delays, and so they're, you know, the school might treat them as a behavior problem because they're not doing their work. But and you know, some kids are obviously having speech problems, but lots of kids are not so obvious. So then,
well, I think in this case, right, you've got this child who appears to have these behavioral issues in the classroom, very disruptive or obstinate behavioral issues in the classroom surrounding any task asking them to do reading and reading
That's-
comprehension, right?
Right, so kindergarten, pre-K, kindergarten, first grade, that's kind of the age when all that gets, started in terms of letter sound, repetition, memorizing, and so some kids need more support from their family.
Mhm.
So with this family, is there somebody else who can read with them? Is there somebody who you can teach the basics of reading, like just spending time, and so lots of parents, they will just read it for them and then the kid will say it after them, but no, that's not how you're gonna teach them. So just teaching parents how to start reading with their kids can sometimes help.
Yeah, I mean, it sounds like the parent is pretty busy with the two jobs, and that most of that falls on the grandparent for the caregiving outside of school hours.
Right, and lots of parents don't see the significance of that, especially grandparents. Like,
Mhm.
this could be really important for you to help him if you would spend half an hour every day just reading with him, and so that would be one way to see that help enough. And if it doesn't, so dyslexia, the whole school system in Texas is on the federal examination bench because of not providing enough dyslexia screening.
Mhm.
So they should provide more, but they used to say until second grade or third grade, but then they shouldn't do that. So, but lots of kids have problems with memorizing sounds or just learning the numbers, basics.
Yeah, that's interesting. I'm thinking about this idea of all of our children and our families, like all our lives move through this socio-political context, right? We're very affected by things like, TEA or the Texas legislature not really requiring or maybe not taking a really keen look at things like dyslexia screening or just kind of general cognitive screenings. And so what we end up with is, I don't know about you, like when I'm not very good at something, I don't want to do it,
Yeah.
Especially if it's, you go into a classroom now and it's like there's a big electronic whiteboard up there and it's like, okay, walk up here and be wrong in front of everybody if you can't do it. And then there isn't a whole lot of opportunity for skill mastery. Sort of like everybody gets 2 tries, and if you go 0 for 2, you need to go sit back down no matter how much you are striving for this skill mastery. And that can be really tough. And I just sort of think about, the inflation, potential for inflation of behavioral disorders in a socio-political climate that isn't really mandating that we take closer looks at cognitive development over other issues.
One of the other things is the school systems that, the past, and I'll put myself personally, that how many kids love math and science now, which is awesome. But in my years practicing, I see more and more, not just not be good at or dislike reading, but hate to read. And that's a deficiency that's gonna create additional problems if that isn't addressed. And I'm saddened by that, because I was the kid who literally realized that I had read a lot of the books on the library shelf, and so wanted to read every book on the library shelf. I was that weird kid, and I had dyslexia, but my mom had taught me how to manage it. And so I think when we have somebody that can address a learning disability, school doesn't have to be the social anxiety, the performance anxiety, the disappointments in their self, and therefore affecting their self-concept and causing all those additional problems. But I think we've had this focus, when you look at the climate, that has focused on parts of school and other parts are lagging, and so they're really, really smart in math and science, isn't that awesome, but they hate to read. And so you start to have these places where that affects behavior and everything else.
And there are so many instances like where I have patients that come in and when we discuss their problems at school, there's a lot of anxiety reported, and that's where I, when it's not clear to me, I really need the help of you all, because there are scenarios where that anxiety is strictly that, it's a performance issue, and if it's, say, related to a learning disability, that needs to be teased out. If it's just an attention issue and a focus issue, it is amazing that in some of my patients, when we decide that it is attention and we get them managed, they come back smiling, happy, and all of that anxiety just improves. And so they're not needing that component, they needed their attention issues addressed, or maybe the learning disability identified. But many of them look exactly the same in terms of their initial intake history. And I've also had a lot of, and I would say probably more in my adolescent, probably highest population, adolescent female that come in, that everyone thinks it's attention, and sometimes it can go under the radar if it's simply attention without the hyperactivity until older, but it's not that common that it goes under the radar. And so I'm always very aware that we need to make sure there's not anxiety, because I've had patients that we are treating ADHD, and they're just not doing well, and their primary problem is anxiety.
Yes.
And so it can all look the same, and that's why it's so important. One of the things when we were talking about this is how can we communicate better, and I think that's really key. Like, if I have a patient that you're seeing and you're seeing a lot of anxiety and you're addressing it, but you feel like that's still a primary thing, I need to know that, so that if we can discuss whether medication is warranted or not. That's a discussion we all have to have together.
And I think that that's a place that I find, where my scope of practice and what I'm gonna manage, if I'm seeing that they're on a medication that isn't managing the symptoms, or the symptoms are shifting out and they're looking more like this than what they started with, it's referring them back to the physicians, to the people that prescribe the medications, and almost coaching them, here's the things to say, and make sure they understand. So the parent that I mentioned earlier with that sleep issue, have you ever told the physician those words, that she only sleeps at most 4 hours? And because if you're just saying the kid has a hard time sleeping, well, we don't know what that means. And sometimes when we're all in a hurry and the parent is just focusing on, I need them to sleep, they're not giving us enough information. She's anxious, she's having a hard time focusing. Does the parent even know what anxious looks like? And so when I'm looking at how do I encourage a parent to go back and talk to the other team members, because it's hard for me sometimes to catch you on the phone and you to catch me, and we play phone tag, which you and I've done a lot, is that whole, so here's what you need to be able to communicate. Here's how to advocate for your kids, because if you just say this, they don't hear all, like you said, you don't get all this.
But I think that's a problem in our system.
Yeah.
Because I think when Danielle asked me, well, how can y'all communicate better? I'm like, that's a good question.
That's,
How can
I don't know
communicate
either.
better? And getting on the phone, especially when it's something severe and more emergent, like I think all of us are willing to get on the phone and have a conversation if someone reaches out that way. But I don't get reports, and I don't get reports from the providers about what you're thinking. So when they come in for their follow-up, I'll say, so what are they telling you? Ask that, like, what are they saying? What's the, and so, but that's less than ideal, because what they're hearing from you may not be
What they tell you.
Yes.
That's always different.
So I think that is an area we can all improve on.
Yeah.
And I don't have the answer. If y'all can provide it, that would be great. But I think that communication can really help. Or if my patient's not coming, I just had a patient in yesterday, and she's not going for her, therapy, and I don't know if it's because she's in a place where she's okay not to go as frequently, or are they just choosing not to go? And they're not gonna always tell me, it may be they're too busy to go, or it's getting expensive, or I don't know. And if I don't hear from, if you were like, why isn't she coming back, and then we don't communicate, I can encourage, I can try to help provide, some other ideas of resources. So that communication's key.
So we do have some settings here locally, like MHID, where the bulk of the providers are under one roof and their offices are next to each other, and that's wonderful and that's great. But for those of us who are in a specialized practice or something like this, really I think we get so busy with our. I can't imagine how many patients you see a day. Everybody's schedule is just packed. From open to close, and then staying later, and things like this. But really considering how we can, in some at least modestly effective ways, communicate about our shared clients is really one of the underlying purposes of this whole program, is how can counselors become integrated into the dialoguing with other healthcare professionals. And Julie, you mentioned something that really stuck out to me is, counseling, we talk a lot about advocacy, and we think about it a lot of times on these like sweeping policy, levels, and it is a legislative session, so that's important to do. But really, advocacy can happen by teaching parents, teaching individual clients how to advocate for themselves, to school districts, to their healthcare providers, to other people that they come in contact, so that they can have access and equity to the things that are available to them. And that is a role of counselors that we don't think of a lot. I mean, I think about our curriculum, and as I'm like scanning syllabi, there may be 1 or 2 points where it's like, today we're gonna talk about teaching parents how to advocate for their children to other providers, or teaching, adult clients how to advocate for themselves to other people. And that's
And
a
I
really
find
important part of the process.
Even teaching at some level the kids to advocate for themselves. Have you
Mhm.
spoke up to your teacher? Have you spoke up to your parents? Did you tell the doctor
Mhm.
that the medication is making you sick to your stomach and you don't feel like eating?
Yeah.
Because your mom doesn't say that unless you've told her, and then if your mom forgets, you speak up. And so those little things,
Yeah.
sometimes we know it, but if you're busy and I've sent them to go see you and they forget to say it, then it doesn't happen. And that's hard. And I find that most of the professionals that my kids are gonna come in contact, whether it's the physician, the psychologist, the teachers, they want what's best for the kids, but their time and mine is all limited. So they are the person that goes to all of us, not me. I have a hard time calling you, and so I've gotta teach the clients that. And so when you go to the physician, make sure you mention in this language,
Mhm.
not my kid has a hard time sleeping, but she's sleeping less than 4 hours at a time. Because that's the key statement that you don't have time to tease out. And that's huge, and I didn't used to do that because nobody told me when I was new to do that. But I have learned over the years that it's so important.
And
It's
you're
so
assuming that
important.
maybe I'm gonna ask that question that way, and so maybe I will, and maybe I
Yeah,
won't,
well,
so
and
it's like.
I got frustrated at times, and I have, with, I've got a 4.5, 5-year-old kid who's starting kindergarten next year, and the teachers are all freaking out because in pre-K, he seems autistic. He comes in my office, and I'm going, how did nobody pick this up? Why didn't the physician, how come nobody has referred this kid yet? There's all kinds of screenings available now. But the parent didn't ever make the statements that made the people on the professional side see it.
Mhm.
And so I literally spent 2 months knowing I'm not really doing a whole lot here, because this is really what this is. It's to build a relationship with this parent and this child so they feel safe to mention this to other professionals. And that became what my role was, because you don't have time to ask all those questions, and if you don't see all the things I see, it's not addressed.
And actually, in your role, you do a lot of advocating for kids and their families, not just to, doctors, but to schools and to all the, can you tell us a little bit about your experiences doing that?
So, I would say generally, like, right now I have a client who's about to age out, turning 18, so she's about to go on her own. So when we go into the schools, I might have to sit in with ARD meetings, 504 meetings, and assist in that way. And when she meets with a psychiatrist or any other counselor, I have to kind of, like you said, coach this young child going to be an adult to more so explain more what's going on. So sometimes when I go with her to her psychiatric appointment, she'll look at me and I'm like, it's okay, go on and tell him, we talked about it. And so she will go to this point of saying, well, this is happening and this is happening. 'Cause maybe mom is busy, like Brandon's mom, or even when we have children, I've had some children as young as 11 who I've had to coach and kind of talk to about like, hey, when you go to your doctors tomorrow, make sure you say this. And sometimes I'll go with them as part of the case manager. We want to go into those meetings because then if they see my face, they remember, oh yeah, we talked about this yesterday with Ms. Ashley. This is what's happening with me. And the mom, like, I didn't know that was happening. Like, yeah, but we talked about it at school the day before. And so a lot of the time when I go into the schools, I'm teaching them anger, but I will ask, how's your medicine? And they're like, oh, well, this is going on. We'll go over side effects. Do you feel this way? And they'll say yes or no. And then I'll put in my notes, okay, we're going to talk about this with the doctor. And I'll go to that. So that looked like sitting in the doctor's appointment because I want to make sure that this child tells them. Because Because sometimes with the doctor, and you guys have seen it, when the parent will come in and it'll just be negative, back and forth, I'm like, hey, well, hold on, you know, this is going on with the child, and I'm there to advocate for that child, but also let the parent understand, you know, we gotta pay more attention to what's going on, because this is what I'm hearing from the child a lot of the time. And so just generally, because I'm so one-on-one with the child all the time, building that rapport, then the parent starts to realize, oh, this child is telling my case manager more than she's telling me, so let me start to listen to the case manager more, let me try to figure out why, you know, there's a strong rapport here than I have with my child, which kind of helps me also build my relationship with the parent. And so we end up having group meetings, family team meetings, and I'll bring in the counselor a lot of the time to my family team meetings. And me and the counselor, the parent, the child will all sit and talk for a good hour about like, what's going on? The counselor will be like, well, we're working on this, and I'll say, okay, we're working on this, what's working for you? To that point, so we're all trying to figure out, maybe we should take different approaches, maybe we should talk about your PCP with this, or your psychologist with this, because we really want what's best for the client. And having, I think a lot of the times I have a few clients who are pretty intense, we have family team meetings, when they see all of us in a room, then that client knows, well, man, I have a lot of support. So they kind of go forward and they're like, I want to talk to my psychologist, I want to talk to my, like, they just want to go to that extent of.
They're ready, right, because they feel supported.
They feel like.
But this isn't how most of it works. I would love it for all my patients. Most people do not have that integrative approach.
Right.
They don't have access to that.
Right. And I would say even
And
case
that's-
managers, where I
Case
work at some point, not all of us do that.
Mhm.
And so for me, I've been there quite a while where I've learned this is the best way for certain clients. And I actually have to go to that extent and say, tell the counselor, I need to have you for like an hour this day. We need to space it out because this child is not following our recovery plan or something's going on. And then we have those kids that family team meeting might be more intimidating. They're like, I don't wanna be in front of all these adults who are probably gonna judge me. And so we'll meet one-on-one and I'll be like, hey, we're gonna talk about this. And we might play a game or something to kind of break the ice in that sense. So it's a lot of the time, it's just sometimes the person themselves, what do they see what's best for the child at that point?
Well, and even that dialogue with you expressing that preference is like this self-advocacy. So you're getting the impression of, you know, working with these kids and you know, coaching and supporting and teaching them to use their voice to more fully describe not just their experiences, but their preferences can really be like a skeleton key for them later on in life that opens up many, many doors. Okay, so I had one topic that I wanted to just see if we could explore quickly away from this case, or a broader topic before we open it up to questions from the folks here. There was this idea that got like heavy nodding from folks about the fact that we live in a world where we're looking for these quick solutions to problems, and that's sort of the world we live in. Can you share your perspectives about, you know, sure there's barriers and some of that dialogue can be helpful, but also opportunities about living in the world we live in where people are kind of ready to act now?
Deep sigh. Who starts?
Stop it, it puts pressure on the provider too.
Yeah.
You know, it does, I mean, you get the sense that it just, that idea puts pressure on the entire system of care, right? I mean, it puts pressure on a 7-year-old kid to be better now, right? And we start internalizing these ideas about ourselves, like, I'm not better quick enough.
Well, and
Like-
literally, I think the barrier, you said, what's the solution? I don't know. But I think it literally comes down to, because of this quick access, brand new clients coming in one session. So are we making progress yet, is what the grandmother asked me. The first session, we have been in a room for 45 minutes. I have just met this child, and your question to me as we walk out is, did we make any progress? Yeah, we got comfortable with each other, I think. I was like, we're just starting.
We
But
know names.
If we know name, no, she didn't know my name,
Yeah.
because she was probably the play
No
lady.
progress.
Yeah, I was play lady, she was comfortable with me, that's what my progress was that day. But it's that whole, I do think that that's it, it's this nowness that even the kids, I think it raises that anxiety we've talked about.
Mhm.
And so kids they're not missing the fact that the adults expect things out of them differently.
Mhm.
And when they don't have the tools either, I think that raises the expectation and the anxiety. Because kids, they get it. I'm the one kid in the class who's always in trouble. All their friends know that they're the one kid in the class who's always in trouble. They get that their family is, I've had kids saying the things like, you exasperate me, or, oh, you're making me so angry, and they get that that's them.
Mhm.
And so where do we start with this nowness is encouraging parents, it didn't happen overnight, it's gonna take more than overnight to fix it.
Setting expectations.
And that's where even my intake, I've learned in my personal private practice, my intake is as much about what I do and what I expect out of them, and not sometimes this. I can get this as we go to the next session. But the first session, they need to know what I can and can't do, what the process looks like, and I need a framework to start. But after I've met their kid, that's when I need more information. And so I had to start in that way, because they come in and they wanna vomit all of this stuff. Well, but hold on, I need you to know what we are and are not gonna be able to do. And when I set my expectations really clear in the beginning, that has helped, because my parents recognize, and again, I mentioned the parent this week, it was a grandparent, she wasn't at the intake. Had she been at the intake, she would have heard me say, it'll take us 3 to 4 sessions before I have any information for you, because I need the kid to be comfortable. They need to get that I'm not the teacher, that there's a process here that's very different than anything they've ever done. So it takes us time. But if I haven't advocated my process, and we use that word again, then my parents don't know, and they do expect, we're all better, right? No.
See, one thing I see is like mental health as an activity is not there.
Yeah.
Like come here, my kid needs to read, or my kid needs to get out of
Trouble at
out of
school.
trouble, right? I mean, and then that this is gonna take time fixing. I try to compare, practicing baseball, practicing a sport, like it's an activity you have to do over and over again, otherwise you won't get better. So this reading problem or this anxiety thing is not gonna get better unless you practice something over and over again, the same way with baseball. So, because what is mental health? How do you get over anxiety? Like, mental health doesn't exist for most people until it hits their family, and then fix it.
Very true.
So advocating, the kid advocating for themselves is also like, I'm different and I have to accept this and it's okay. Well, that's a long process, because all along the way, you feel different from everybody else, but them having a voice and explaining to you how they see that problem, or even to recognize that they feel different from the other kids, and what helps them. Lots of times the parents tells the whole story, and that's the anxiety of the parents. But if you can teach the parents that your kid has this story and he has a lot of thoughts about it and he's really stuck there, and you could help by listening. For example, he tells a story and listen to the story, and you can accept how hard that is. That's kind of like a starting point for them to change too, because that anxiety component gets to not showing, not talking.
Yeah. And I wonder how we go about that. I wonder how we communicate not just to individual families or individual communities, but just in general about that our shared, profession is one that really involves a lifestyle of mental health, or a family embrace of things that are adaptive and helpful over time, rather than treating, a depressive episode or an experience with anxiety, the treatment of that like it were an oil change or something like this. Go on,
You mentioned us in the legislative session right now,
Mhm.
and I know Todd Hunter has been doing something locally with the response to the suicide issues that are happening in the schools. And somebody came who's on his team to talk with me and was asking me questions. Well, they were looking at this as a response because of what's happening in the high schools, and I work with little kids. And so I said, well, we got to start when they're little.
Yeah.
We can't throw people into the deep end and when they're drowning, teach them to swim. If we can't see mental health as an issue of learning and practicing good mental health from the time kids are little, how do they regulate when they're overstimulated? How do they calm themselves down when they're angry? What do they do when they're scared? What do they do when they don't know how to get along socially? If we don't address these things when they're little, by the time they're in high school and they're in the deep end, they're drowning. And so we keep looking at the high schoolers and looking at how do we keep people from drowning, when we don't realize you're talking about practice. We gotta teach them to swim, and they need practice. And so my whole focus in my conversation with this person was, it's mental health as a school initiative for little kids that grows as they get older. Because we can't expect people, but I had an 8-year-old tell me, and it was my favorite example. He came into a session from an outburst at school, he'd gotten suspended, he had upturned a desk and had a big outburst. Mom got in the car with him and they were on their way to the appointment, and she says, so what happened? And he says, I don't wanna talk about it, that's why I'm going to Miss Julie. So she comes in telling him all the things that happened wrong. He sits in my office and said, wow, what a big day, what's going on? And we're talking about it, and he says, I'm so tired of all the adults telling me to breathe. Of course I'm breathing or I die. And I was like, wow, he has no clue what we mean when we say take a deep breath. So that's where I started. And it's that he's 8, and he had been hearing from everybody, count to 10, take deep breaths. He didn't know what they meant. So he was going, I am breathing or I die.
Yeah.
Then it makes him angrier, and he upturns a desk. And so it's some of that stuff. How are we teaching kids to calm themselves down for sleep? How are we teaching them? It's because some of these things, they don't need to come to us if they have those skills.
Yeah, and that's, like the proposition behind groups like Castle and them who think that, our best shot at inoculating our community to things like stress and depressive episodes and things like this comes through intentional and prolonged exposure to school-based supportive interventions, like simple things like social skills and stuff like that.
Well, kids aren't doing it, it's a different world. It's a different world, and in this quick now kind of atmosphere, even play looks different, socialization looks different than it did even 10 years ago, certainly more than it did 15, 20 years, no matter how many of us in this room, what age or is, it's different than when we were in school. It's very different. And so if school is the one place we get a large number of kids, unfortunately, school might be where we have to address some of these issues.
Well, thank y'all so much for considering some of these things. I'd like to open it up to our group here. We have about 10 or 15 minutes to field some questions. Anybody have a question for our panel or someone on our panel? Yes.
Yes, I have a question. Being that New York just got, they just started this law in September, starting in the fall, that they're gonna mandatory mental health classes for pre-K to 12, and they're gonna add it to the health curriculum. Do you see that ever coming to Texas? And if so, or if not, what can we do to add that?
Wow.
The first time I hear about it.
Yeah, I was listening, I was going, they've done what?
Oh yeah, it was just announced in September.
Wow,
Okay.
awesome.
And what did they do it in response to? Like,
I don't know the exact response off top. I just know that it was like pretty big news because it's the first state in the United States to mandate mental health courses to the health curriculum.
So I can just sort of give my opinion about this. So I think that it's not something that's gonna happen this legislative session. But some cool things that are happening this legislative session are, the Texas Education Agency will now be required, all schools in the state of Texas will be required to evaluate, monitor, and report on school climate, emotional and psychological and social well-being of all of their students. And that information has to be publicly available on that school's website. Like, that's huge, right?
That's massive.
Things like schools in Texas now being mandated to report the number of school counselors that they employ
Yes.
and report the ratios and percentages of their activities. That's new, right? Like, that's huge, because before we were like, no, we have school counselors in Texas. The things coming through this legislative session that will kind of open the doors for LPCs to be on a school campus, right? We're sort of seeing a glimpse into the future of what that looks like at West Oso ISD right now, where they have some of our Tex-CHIP students doing mental health jobs in the high school there, clinical mental health jobs, and it seems like it's going swimmingly. This type of paradigm, I think, in my opinion, at least in our region, is going to get its foot in the door through the smaller districts like Flower Bluff, their principals on Todd Hunter's commission, West Oso, who just has a group of people who are like, let's just do this. I think that we'll get the foot in the door through those smaller districts, and then probably larger districts will follow suit because, you know, not that they're delaying, but because it's hard to organize and mobilize things in a district that is as big as like CCISD or, you know, Northside ISD in San Antonio. I think it's not overnight, but I hope that it is on the way, certainly within the next, you know, 6 to 10 years or
Well,
something.
and I'll add to
Yeah.
that, Stephen, that we were talking about this advocacy. This is where we as mental health professionals, that when somebody calls me and says, hey, I'm with Todd Hunter's commission, can I come and talk to you? Yes,
Yes, you
and
can.
let me talk.
Mhm.
And you know what? If he wants to talk to me, I'll sit down and talk with him. And so being those voices, that when our friends and our family are speaking up about what's going on in their schools, helping them recognize the school counselor, most of the school counselors we know don't do counseling.
Mhm.
They do academic, ARDs, they do the little middle, they do these lessons in the classroom, but they go into the classroom on average, like, what is it, 2 times a year, like 6 weeks, I can't remember.
Once a 6 weeks.
Okay, and so most of the parents don't know that stuff.
Yeah.
And so we, as mental health providers, when people are up for, you know, when the judges are being elected, when the school districts are being elected, when they're talking about different things, we have to be the voices for what happens in mental health, because it's our job. It's what I do every day, it's not what they do every day. I don't know anything about plumbing, but when I have a question, I know who to call. Well, if I'm in a conversation with somebody and I'm not speaking up, then I'm not providing what you're discussing is how do we get it into our state.
But
By doing those
this
things.
Texas mandated reporting to council, is that gonna reflect on that? Like how much time do they spend counseling?
No, so this was in the last legislative, and it was just getting through the door to say how many people are employed here full-time as school
Okay,
counselors.
that part.
And that's it, so there's like one line in
Okay.
the annual reporting system.
Okay.
We had another question right here. I see you, Tricia.
Oh, yeah, I was kind of wondering, you sort of pushed that door open just a little bit, but I'm curious about some of the institutional barriers, like from any interaction that you had with a principal or an administrator or a superintendent with that, because we have the school counselors, but they're kind of lower on the totem pole in terms of the greater hierarchy.
Mhm.
And can you speak to, in terms of advocacy or information or connections, what does that look like? How do we kind of overcome those institutional barriers to make that happen?
I guess for us recently, we've had issues this past fall of where we've had a few schools that would not even let us in to speak with the clients, most particularly high schools. And so we've had to go about it, you know, updating our MOU, actually talking to the superintendent, we had to get our CEO involved because there were these barriers that were popping up and it was hindering the development and progress of the child in their session. So I would say to get through those barriers, it's more of just correspondence of, you know, that professional scope of things and like, okay, well, this principal at this high school saying, you know, you can't even come in during electives, you can only come in 10 minutes before school and 10 minutes after school. I can't do anything in 10 minutes, I could probably play a game of Uno. So it's more like, how do I go and advocate for this child and work with this child? So I would say as far as what we had to do to kind of go over that barrier is obviously find times outside of that school when I have to meet with that client after hours, before hours. But as far as getting into the school, it's just more like coordination of services. Okay, well, let's talk with the superintendent, which was worked really closely with our center with CCISD these last few months. And with that high school, we've had, like going back to Flower Bluff, presenting to that smaller community group. He's actually made, I believe, most of the staff listen to what MHID has had to say about mental health. And so it's more just educating the professionals in the school. You know, this is a very big topic, and you hindering any type of professionalism is doing more harm than good. So that's what we've had to do recently.
And I think what, just institution, I think what you're reminding me of is even just my weekly sessions. I have to sometimes advocate with the school, yes, the kid needs to come weekly, and sorry, I can't see every child after 3:30. There's only so many appointments in a week. And so being able to work with a parent in the school, I can try lunch, I can try PE, but technically kids then don't like to come because I had a little girl that literally, I missed chicken nugget day.
That's right.
Okay, let's take you off of Thursdays and try Tuesday. And so little things that,
Yeah.
you know, she didn't wanna come to counseling anymore because she was missing chicken nugget day, but anyway.
It's pretty good.
It was pretty cool. And I get the kids that were missing PE and recess, but it was the chicken nugget day that was hilarious. But it's being able to advocate for the school, there's a reason why I need the child weekly. Yes, that means that their appointments are gonna interfere with school,
Mhm.
and advocating that the parents know if you have a 1 o'clock appointment, you really do need to take your kid back to school. And some of that type of stuff that a few years ago, I don't know, it happens for you guys, because y'all see each other, y'all see your kids like several months apart. So one dentist appointment, one doctor's appointment isn't the same as the weekly. But that was a barrier I had to overcome, was talking to superintendents and school district people that this is needed, and this will improve what's happening overall for the child. So,
Or telling the parent, you know, we've told parents, we need to go and advocate as well.
yes.
And so we'll tell the parent, you know, go and tell this principal, like, my child needs this. I've had a parent in the past that was like, I'm gonna sue the school. I'm like, let's not go to that extent of suing the
Take a
school,
deep
but breathe. But this one parent, he was very adamant. He was like, my son needs this. He's been going through so much lately, and so we've had to tell parents, you need to go and also advocate for your child. And with those steps and with our steps, we were able to get into that high school. And high school now lets us go during your electives, which before was nothing.
Yeah.
And so it is a process. I would say get a lot of the family, parent involved as well to go over those barriers.
Right.
Excellent, thank you. Question in the back here?
Oh, it wasn't per se a question, but rather a comment. I know that right now there's, some Senate discussion, there's actually a bill that's regarding school counselor time.
Mhm.
I'm a school counselor,
Mhm.
and my colleague is also a school counselor, been counseling for a while. And the issue is, we're there, and we're both LPCs and like therapy people. However, the issue of time is our problem.
Yes.
We are so bombarded with other tasks and ratios. I have almost 900 students on my caseload. She has about 500, 600 or so. And it's just one of me, plus all the other duties I do. So this bill that's actually right now, from Senator Lucio in Brownsville, is mandating that school counselors have 80-20% time. 80% of your time is direct student contact, and the other 20% of time, is for other things.
Mhm.
And then there's even stipulations into your contract, because what also happens is you might have, other duties as assigned.
Mhm.
So, okay, well, yeah, that's not technically written in your contract, but I'm giving it to you because I can assign you the duties. Well, under that bill as well, there's that stipulation, you cannot add those types of things in to school counselor time. And that would alleviate a lot of problems, because I know we do go into the classes. I'm on a 3-week rotation. Granted, I don't have a kid outside screaming or running after the parent, or chaos is breaking out at my school, but, you know, we hope that that bill would pass. That way it would
Mhm.
help us, because we collaborate a lot with doctors and mental health and all the different people that are involved with helping kids.
Yeah.
And if that bill were to pass, I think that that would be a real strong shift, because we would be able to do what we're supposed to be doing in school and be there for the kids.
Absolutely, and that was, I think, one of the big justifications for Texas moving towards the Texas model for school counseling over ASCA's model, because it prescribes these times, and it has a lot of very clear determinations about what the duties and activities are per week by percentage. Excellent. Yes, in the back.
Alright, so I just wanted to cycle back to when we were dealing with the kids that don't sleep well and that they're having sleep issues and stuff along those lines. And tie it sort of in with the play therapy with you. When you're doing play therapy in an office, it's a very structured thing to get a very, specific goal. But, we spend so much time on electronics, and we use electronics for babysitters for kids. Kids don't have the free play that they used to have in schools, because they're trying to cram everything in under the sun, are eliminating recesses at earlier and earlier ages, so the kids are not getting this free play. Is
Mhm.
that something that you sort of use as part of your sort of support and prescription for helping this child?
Part of when I've talked about my intake process being that I spend a lot of time what I do and don't do, one of my little comments to parents is, whatever has brought a parent in, all of us as parents deal with those things that are difficult, picky eaters, not sleeping, tantruming because we want the toy at the grocery store. So I provide information to parents as they ask, but also I have resources in my lobby, in my waiting room. Instead of, cosmopolitan magazines, I've got parenting books. And I've got flags on certain things. And, if there's something you have a question about, ask me. I will try and direct you to a resource.
Yeah.
Because if we're talking about the things that this little boy came in with and they didn't mention sleep, but we start to recognize that that's an issue, is some of that just hygiene, kind of like if we're looking at nutrition. Do you know that your kids shouldn't be drinking that much soda? Well, the physician, if the kid is gaining too much weight, might be able to go over that, but it also means that there's extra sugar on their teeth, blah, blah, blah. So sometimes I think parents don't know that you're talking about electronics. One of the things I've been telling all my parents is the blue light filters and those things. Put those on your tablets, on your telephones, on everything for you and your children. That some of those little things, it's hard for me to get to in a session, but I try. Because it's that hygiene of mental health and what is helpful, and because we work with kids, people don't know these things. That kids don't come with the instructions, so where are they hearing it? Where are they seeing it? Sometimes we are those people.
Well, some aspect of like the YouTube channels and what kids will watch repeatedly and what parents don't know that their kids watch repeatedly. I mean, they have their own like obsessions and that's all they do, and that takes away playtime or play, free play that's much more imaginative. So,
As opposed to being on YouTube, watching a video of someone playing.
or somebody.
These are real things. These are real things. Like kids watching videos of kids playing.
Don't you feel old school when you start to look at that and go, what? Yeah, well, and it's that idea that kids are bored anymore.
But then the parents, I mean, us knowing to ask the parents that as a question, then to
Yes.
see the impact and that
Yes.
parents, educate parents to have time away from those apps and that.
Because when you ask a parent, what do they do in their free time? Are they playing? Well, they all play Fortnite. Well, what else do they do? Well, they don't want to do anything else.
That's a
But
big
they shouldn't be
problem.
doing that all the time. So how do we, it's all that stuff. Play is important.
And I would second the sleep hygiene. I mean, the majority of my patients that come with sleep issues, that's our primary discussion in the beginning. Let's look at your schedule, let's look at, even from when they're babies,
Well, I
There's a
gave
lot
them,
about
I gave them the
sleeping
tablet and they played with it and then they wouldn't go to sleep. Yeah.
So we have time for maybe one more comment. Go for it.
It's a comment, and one thing in counseling school, when I was in school, we were never taught the importance of the connection of the primary care provider.
Mm-hmm.
And luckily, my first job, everybody was connected, but the main thing is counselors, when we have an intake, we have that moment in the parent's perception. The primary care physician has the baseline and history from birth. And they have understanding of things that we don't, but when we can give understanding to what they give, but we get that first picture, and we don't always know the long baseline, and the parents don't always tell us that long baseline. And where we may overlap, we don't want to be saying things to the parents opposite of what the pediatrician is saying, when it could go either way, where we haven't discussed with the pediatrician those things. It requires disclosure because of our confidentiality, but we only see that picture of moment. The pediatrician does have from birth, they have the traumas that children have gone through operations, and they know the social histories of parents changing and divorces, things that we may never know through the tiny glimpse we have. So I strongly, strongly believe, not just in the pediatrician, but anyone professionally in part of that child, that we come together. But I really strongly believe we need to be part of the pediatrician's life, and that they know what's happening, that we still follow our ethical codes and get all the signatures for disclosure.
And I will support that pediatrician would appreciate that input, because we don't always get all the information you get. I mean, I may know a child for 10 years and not know some information you get in your second conversation. They never told me that. They don't even tell me sometimes when they've been divorced. like, they don't share it, and they come in and out, and you know, it's not a question every time, are you still married? Like, we don't, I mean, we don't have, and they will tell the nurses more than they tell me sometimes. There's a whole, they filter, we all filter, don't we? But that communication, I mean, is really important.
Well, if you want some of our insurance, we got some. So thank y'all very much for your time this morning. Well, very, very